afternoon, guys. Welcome to the Outperform webinar. Today, very quickly, I'll recap what we did last time so that people who have not attended last time get a feel for what they missed out on. Last time, it was about pronated feet, um, also about flat feet, essentially, and how the foot tends to roll inwards. And we spoke and showed pictures on what happens when there is pronation to the foot. How does pronation of flat feet affect the kinetic chain or the muscular chain, the domino effect that it has as it rides up into the skull? Then Srinand spoke about what happens, how do we assess it, what are some of the clinical symptoms. Abhishek came in and spoke about looking at strength and conditioning work, how to assess, how to look at putting together a strength and conditioning program to better your feet performance and therefore better your running performance. Today also we are going down the same path. I'm going to help explain what are some of the biomechanical changes that happen with supinated feet and what are the kinetic chain changes that it makes as it travels up the spine and how does it affect the runners. So here we see a couple of runners running through, and if we notice the runner on the right, and if you follow that arrow mark or that line, the way they land, which is on the outside of the foot, is the action of supination. Although those kinds of things need not be so obvious, you can still land there and become and have a neutral feet. But people who have supinated feet or high arches tend to land very much on their sides of their foot, the lateral aspect of their feet. So today, just like last time, we're going to look through the anatomy of the foot. How does the high arch look like? What's the kinetic chain? What really happens in one set of activities, such as a squat? Sorry, I should have changed that to high arch. Very briskly, the feet and the anatomy of the feet, it consists of 33 joints. It's made up of native bones, and foot is essentially a platform. That means it allows for your center of gravity and center of mass to move over. It also is a distributor of force and pressure. So that is its essential function. It also provides a feel for what you're stepping on. So one of the functions is a tactile sensation or a hepatic function. The three types of feet, again, we covered this last time, so I'm going to go through it very briskly, is that there is a pronated feet, which is the low arch or the fallen arch, or not fallen arch, low arch or no arch. Then there's the normal neutral foot, which has just the right amount of arch. And then there is the high arch, which is the supinated foot. The diagram on your right top hand corner shows you a comparison between pronated and supinated. And it basically goes to show that those who have supinated feet, their alignment tends to be outward bound, whereas people who have pronated feet tend to have an alignment that's internally bound. So a lot of the issues that come up, which Srinand is going to take you through in terms of symptoms of pain, etc., he will cover as to how that happens. Then on the bottom right hand corner, we have a kinetic chain showcasing what happens in pronated feet, where there is an internal force that is being applied. With the supinated feet or high arch feet, there are forces acting on the outside. So if the ankle tends to supinate, that is more out, abduct, then the tibia tends to rotate out. And if the tibia tends to rotate out, the hip also tends to rotate out. And if the hip tends to rotate out, there is a chance of a posterior tilt, and therefore a kinetic chain or a domino effect tends to go up into the spine. Lot of the supinated, lot of the high arch people tend to sprain their ankles very easily, and that is because of the way the foot is positioned. So we'll see how that looks when we do a squat. When I show you a squat picture, the um, just a quick tension drawing slide here, a picture here where on the left hand corner there is a normal foot position and a high arch position. It is basically, high arch basically means that there is a great tunnel between the foot and the floor. If you stand on one leg, you should be able to insert your fingers fairly deep in and almost come out of the other side if you can. You won't, but it just is the case for it. Okay, this picture isn't very clear, but it tends to convey what I wanted to convey to you. Is the black line at the bottom, which is a smudged line at the bottom, shows where actually the foot is, where your pressure is on that foot. And what essentially happens is the foot tends to roll over onto the outside portion of the foot, on the foot, which tends to cause a lot of torsion effect at the ankle. Remember, this is a squat position, so this is a moving position. So moving positions are very different to what you saw earlier on your bottom right-hand corner, where everything was moving out. So that is where the general tendency of the bones are to move out. But what happens in a movement is that when a movement gets created at a joint, it produces an effect called torque. Torque is not a rotating force, it's an opposing force. So therefore, what it causes at the ankle joint is a lot of tightness and stiffness to keep the ankle in position, which affects how the knee will flex and how the patella will track as you go up and down. And then ultimately into the hip as well, it'll ride in, and therefore causing a lot of lower back issues when you start doing squat work, especially beyond the 90-degree squat alignment.
Today, I'll be talking about how high arch runners or runners with oversipination, or some people even call it underpronation, present at the clinic, or how they normally present at the clinic. Just going through this picture again, the reason why I brought this picture up again is this is just to show the pressure points when you look at it from top. On the top slide, you can see our flat foot presence. We've spoken about that previously, and a normal foot, how the weight is evenly distributed all over. And then you can see the high arch foot. Again, depending on the degree of the arch, you can see different pressure point. The reason why I brought this picture into the place already, even though Paddy's already covered it, this is one way of self-diagnosing, answering Nirav's question, is one way of self-diagnosing whether you have high arch feet or not. It's simple. You step into the bathroom, make sure your feet is wet, then go step on a flat surface and on a dry surface and see how your footprint comes. Or if you're lucky enough to be near a beach area, just go for a stroll on the beach and that will help you. Another reason why this is important is this is very diagnostic when people bring in their shoes. As you can see, the pressure points are usually, there's no pressure taken on the middle of the foot or in the medial longitudinal arch, that's the term. What happens is people usually tend to have, if this is my left shoe, this part tends to be worn out. You will just see this part being worn out and all of this being normal. So anybody who comes in with any foot issue, anybody who comes in with any leg issue, I always ask them to come in with their pair of shoes. So this is a very vital piece of information for us. Another picture I think I would like to highlight is the closed kinetic chain. As you can see in a neutral foot, how the alignment or the transmission of force or torque is going up over here. Whereas in a hollow foot, how it's going to the side, and an inner foot, it's flat foot is going to the inner part. This is the topic for another day, but you can see how it's going out over here. And that will explain the next slide to you. What are the causes of oversupination? I'll use oversupination rather than high arch over here. Very often the two are used synonymously, but there is a subtle difference. Yes, if it is an inherited structure, then it's in case of an inherited structure, then a high arch and oversupinate would almost become synonymous. People like how you can have inherited flat feet, some people can have inherited high arch feet. It can be due to just unusual fusion of the bones or just a little tight contraction of the muscles and all of it. Improper shoes is a very, very, in fact, I feel this might be one of the most common reasons out there because very often people tend to have this. Everybody thinks insole shoes are the right shoes for running. I know, and I mean, I've seen this very often that because I had leg pain, I had calf cramps, I went and spoke to my fellow runner or something. He said, buy insole shoes, they work for me. So I already have a good arch or I have a slightly higher arch. And now I go wear a shoe with an insole, I'm just going to accentuate or worsen the arch. So this is just going to cause more issues and stuff. Prior injuries are also a risk factor for or can cause oversupination or think any fracture or any injury to the calf muscle, any injury to the peroneus muscle. That's one more special muscle in the foot over there. All these can actually cause high arch thing. These are all the causes of oversupination, and even though it's not as commonly seen as overpronation, it's something we should keep in mind. Um, yeah, what is the injury mechanism? Now, why do we, even though we say like supinated people are supposed to have like a fast, like a very fast takeoff or something? I don't know. I mean, it's not to that. It's not that evident though. Anyway, so what happens over here is that when there's increased supination of your foot, your ligaments around the ankle, ligaments around the thing tend to become very tight, and the muscles and the ligaments, all the soft tissue structures tend to become very tight. And when this becomes very tight, what happens is the mobility of your ankle, your ability to move your ankle in all directions, up and down, right and left, rotations, all of it, everything reduces. So once that happens, your shock absorbing mechanism of the foot reduces. Say you're 80 kgs, and now every time when you run, every time you land on your right foot, you're loading 80 kgs on the right foot. Every time you land on your left foot, you're loading 80 kgs on the left foot. So this can reduce and once your shocking mechanism, so think of the ligaments and the tendons and muscles around the joint as the shock absorbers, and the joint is the main structure, the bone is the main structure. Now the shock absorbers are not working properly, all the load goes onto the bone, and this is one reason why bony injuries are more common in high arch runners. In fact, there was a study which showed that typically medial flat foot runners come with inner thigh injuries, inner ankle injuries, soft tissue injuries, whereas high arch or oversupinated foot runners come with bony injuries, outer ankle injuries, outer knee injuries. Yeah. So like I said, this is what I just discussed in the previous slide. Pain typically comes on the outer part of the ankle, outer part of the knee. So like we saw, it can cause a whole cascade all the way till the shoulder or the neck. It can. But let's stick to the more, if we go digging into that, we have too many symptoms and signs to deal with it. The whole point of bringing that up is that whenever somebody, any runner or anyone who's involved in any activity that involves running comes and talks to you about, or comes says I have some sort of issue, you have to examine from the foot to the toe. Just because he has a shoulder issue while running, or just because he has a neck issue while running, you can't ignore the lower part of the body. A lot of people just tend to focus on that part. They don't see how the whole connection can come from bottoms up. Yeah. So higher incidence of ankle injuries because, as Badri mentioned previously, the higher degree of instability and also the way you're landing. Look at this. If you look at this picture over here, there's such a broad surface of the foot, and he's just landing on the narrowmost part of his foot. He's not even using the broader surface of his foot. He's using the narrowmost part of it. I mean, this obviously has more stability, but landing like this is going to topple your whole body. And bony injuries are more common. We just discussed that in the injury mechanism thing. Uh, Diversifying a little bit over here because very often high arch runners present with ankle issues rather than the foot issues per se. So what I've done over here is I've just shown you a couple of, and the most common ligaments at risk are the lateral ligament complex of the foot. Among that, the most common is the anterior talofibula. Sorry about the technicality over here. There's anterior talofibula, calcaneofibula, posterior talofibula. This is just to make the presentation sound a little fancy, but then these are the ligaments which can. The reason why I've highlighted three different types of ligaments over here is because depending on the type of ligament that is injured, that determines the type of rehabilitation process you have to go through. And so these are the ligaments which are at risk on the outer part of the foot. Uh, just how do we diagnose this ankle, whether it's a ligament injury or not, is by doing one is we have to determine ankle stability. There are a couple of tests to determine ankle stability. One is the anterior draw test. That I'm not going to go into the details of the test, just to know that, because that's another topic. When we come to ankles on another day, we will discuss this in detail. This is just for you to have an idea. Anterior draw test is when we check for the anterior talofibular ligament. Talar tilt test is for to figure out the calcaneofibular ligament, and posterior draw test to posterior. Actually, you can even forget that, we hardly see it. I've not seen it. It's very, 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 unless the force has been so massive that you twisted your ankle so badly that it's ruptured the posterior talus. Very rarely. You don't see that very often. Uh, this is important, and usually these tests are quite diagnostic on their own. Very rarely do you need imaging or anything in case of ankle ligament injury. We'll talk about imaging in a bit. These are the ligaments. And the common bony injuries, like I said, bony injuries are more common in high arch runners than in flat-footed runner, and this is one reason. If you can see these two pictures where I compare a flat-footed runner and a flat foot and a supinated foot, those red marks show us the pressure points, and you can see over here that in the flat foot how the sole of the foot is taking all the thing, and that causes a headache on its own. That's a different type of plantar fasciitis altogether over there. And what you can see over here in the supinated foot, you can see how the pressure is solely distributed to the this joint is also called, another technical term here, it's also called the metatarsal phalangeal joint, if you want to remember that. Or it can happen on the calcaneal bone or any of the heel bone or anything like that. So or the talus. So what happens over here is these bones, in particular, because of the repeated stress over here, these bones become more prone for stress fractures or stress reactions or any of these things. And this is just to highlight the bony injuries. How do we diagnose a stress reaction or stress fracture? Ideally, typically clinically, they have persistent pain and swelling at a single point, and you're like, just a simple tap also makes them scream in pain, and that's how you can figure out it's. And on the bony part, it's just a thing. Or you have to do an X-ray to make sure to determine the degree of the. If you suspect a stress fracture, you have to do an X-ray to figure out what kind of fracture, whether it's a fracture or whether it's just to rule out a fracture, at least if it's just an ankle ligament injury or something. The other thing is sometimes there is something called an X-ray. They show something like a stress reaction. So your doctor or your therapist might ask you to do something called as a bone scan. This will show us that whenever there's an X-ray is doubtful, a bone scan will help us determine it. And then there's an MRI. It's every I mean, I know. I mean, without sounding, without criticizing any other doctor, this seems to be the favorite investigation, the investigation of choice for a lot of doctors. You have any pain, you have any injury, go get the MRI first, and that will tell us what we have to do. Unfortunately, MRI can be very detrimental in that situation. You do an MRI when you're suspecting associated soft tissue damage, and or if you suspect a combination of ligament and bone injury, then it's an MRI is done. Yeah. Um, Treatment, acute management. You might see that if you attended my talks before, or even if you attended last week's talk, I always start acute management with police protocol, because it stands for protection, optimal loading, icing, compression, and elevation, because this is the standard for any acute injury management. It makes sense. You can apply it to any injury in that thing. Anti-inflammatory medicines on a case-to-case basis. I've come across a lot of patients who are scared, or not patients or clients or sports people who are scared to take anti-inflammatory medicine. It's I don't know whether it's and they're just scared. They're like, it's okay, I'll do anything to get rid of the pain, but I will not take anti-inflammatory medicine. So that requires a little bit of education from our part. It's good on an immediate short-term basis, but not on a long-term basis. Avoid the harm factors like heat, alcohol, running right after, just because the pain is settled down, running right after it or loading it. And M stands for massage. A lot of people, because of the whole advent of soft tissue release, deep tissue massage, which is very good when used in the right way, people have the tendency to think, okay, let me do a self release, a self massage on that spot which is hurting and figure out if that's going to help me, then done, I can go. That's a vital mistake. That's the acute management. Long term management is, of course, acute management is also figuring out if it's a fracture, then it's an altogether different thing. We might have to put a plaster or a cast and all of that. Long term management is finding the right shoe. Please, you need to know the difference between a cushioning and an insole. An insole is really firm and hard. It's going to push that flat foot up and give you that arch. A cushioning is just going to cover the deficit so that there is a little bit of low differentiation from that thing. I think Abhi might cover a bit on the orthotics part of it, but finding the right shoe is very important. Please don't go for a commercial based shoe. Please I mean, you can go for a commercial based shoe, but just consult someone who's familiar with shoes and stuff before going into this. Then a lot of ankle mobility and stability work. This is very, very important because as we saw earlier in the injury mechanism, because of your reduced shock absorber capacity, you tend to have a, what do you say, your mobility and all is reduced. So you need to work a lot on mobility and all of it, which will all be mobility and stability work, which will all be covered in the strength and conditioning session. And finally is losing of tight tendons and muscles like the calf muscle. Sometimes very tight calf muscles and all can, or a lot of peroneal muscle irritation and all of that. All that needs to be relaxed, trying to figure out some progressive stretches, progressive flexibility work that will loosen that thing. That will also reduce the arch, or even stretching the arch. If this is your foot, just stretching the arch like this, that will also relax a bit. One point I would like to highlight is the plantar fasciitis. Plantar fasciitis is something that can happen in flat feet, neutral feet, high arch feet, everybody. The only difference is plantar fasciitis. The whole palm or the whole plantar surface of the foot has fascia. You have a medial longitudinal arch, you have a lateral longitudinal arch, you have a arch over here, a transverse arch over here. Anywhere can present with plantar fasciitis. So yeah, so Saurabh's asked me what is the harm, and harm stands for heat, alcohol, running, and running right after the injury and massage. So heat, the reason why I specifically said this is people very often don't know when to ice, people don't know when to apply heat therapy. Very often you see people who are applying ice for weeks together or months together, coming and telling me, apply ice, the pain doesn't go, I apply ice, the pain doesn't go. And very often I have people telling me that I twisted my ankle this morning during a run. I went in on, and I know if I apply heat, it's going to get better. So I went and applied a hot water bag right after twisting my ankle. So that's very important. You need to know. Usually, my recommendation for people is in the acute phase, you apply icing because you want to try and control the bleeding. You want to cause some vasoconstriction, you want to limit the swelling and all of that. Beyond 24 or 48 hours, icing has no role over there unless you're undergoing active therapy or something. Icing has no role over it. In fact, it can become detrimental to your recovery process. There are studies that show that it actually hampers how your muscles heal together, how your muscles tissue repairs itself together.
Because the inflammation is part of the healing process, and
yes,
it slows down inflammation. So exactly. I guess that's an important aspect there. I
Yeah.
consistently do ask my athletes who are undergoing rehab, because especially probably the phase 1 of rehab, which could be beyond the acute phase sometimes, depending on the degree of injury. But that's majorly because I'm looking at improved blood supply to that area. So it's actually the effect that I'm looking at when the ice is off. So when we go off the ice, so we've seen enough changes, like the whole game ready aspect, which we use game ready for handling the inflammation. And it's got action compression. The whole philosophy behind that is it has about an 80%. I don't think it's actually 80%. I don't remember the exact number. It's about 60 to 70% increment in amount of blood flow to the site. So we're looking at recovery, and it's the same philosophy in which we're trying to do ice baths, because it's got a lot of slack from the past. So I still use it as a modality, but more than anything than handling inflammation, I'm looking at improving recovery time, so we can load the
Right.
tissues again.
Right. So usually you use the game changer after like a session or after some soft tissue, something. So you
Generally,
already,
when I've done some
like you
work,
said,
but I'm also do it post. Like I said, in phase 1, a lot more. Then in phase 1, I have a lot of assessments tagged on a daily basis to look at changes that can happen. Because when you're progressively loading, especially what is most important is to get optimal loading, which we need to consider. So sometimes when we are looking at optimal loading, we can have a day when there is a lot more inflammation than what we suspected, hence we'll need to regress the mode. So there is a little bit of a back and forth that can happen initially in rehab. So that's at that point to handle inflammation and help him recover, so that we can sometimes undo some of the changes that was unnecessary. That's what happens. So I think any question, guys, we can address that now. So that why don't we just move on to the next?
I know there's one more question about one guy asked about anti-inflammatory medicine. He asked, is it good or harmful? And so anti-inflammatory medicine on a short-term basis, again, it depends on the severity of the injury, depends on the, if by any chance, if I can get a patient to, or a client to recover from his inflammation, I think without using anti-inflammatories, I'll be more than happy to use it. But worst case scenario, I won't hesitate to use it if he needs it. There is no, people have this, on a long-term basis, yes, it is bad. People usually have this tendency, like I've seen that very often with marathon runners, just because they suffered from ITB syndrome the last time, they're like, okay, let me take an anti-inflammatory before going in for my run and I'll be okay for some. And that tends to become an habit. That in such situations, anti-inflammatories.
The simplest way to answer his sorry, Sri.
No,
simplest way to answer his question is the fact that one, we're looking at normally most anti-inflammatory medication do come with a certain amount of ibuprofen or some supplemented pain killer kind of effects within the medication, and which would, in other words, bring down excitation potential of the muscle as well as the reactiveness of the Golgi complex at the joint. So we would see that you're not aware of the damage happening. If there is inflammation happening due to a movement, that means there is
basically hidden over there.
Bleeding happening within. You might be clearing out the bleeding, but the bleeding is happening because of tissues being ruptured, or there are mild amount of strain. So you could go from a mild strain to a grade 1 and a grade 2 within one event itself. And the difference between a mild, for example, an ankle injury which you spoke about, the difference between a mild lateral ankle sprain to a grade 1 to a grade 2, the difference is almost about 20 days each. So, and if mismanaged even at the grade 2, then we are looking at a surgical modality that might need to come in, and then it becomes really difficult to handle. For example, you spoke about having guys who have the PTFL injury, which you said, which is very uncommon. But I've seen PTFL injuries in footballers because of the mismanagement of the other two ligaments. There's such a large on the PTFL, and that's when you see that happening. So that's a common thing. I'm just continuing from Sri. He was speaking about all the injuries that are presented with over-supinated feet, or which is supinated feet or high arch feet. What we look at and how it represents or how it presents as painful IT band friction syndromes and ankle injuries, which you guys were talking about. So I'm kind of not gonna cover on management of that. I'm going to just speak about how we can look at doing corrective work. So it actually gets a little tricky when you're looking at corrective work for this, because it's a lot of the times that I've seen that we obviously do a lot of soft tissue work, and in the soft tissue sites that present as pain is generally, you would also see the IT band, you will also see the you'll also see, like I use this same thing from the last time because this is the superficial posterior line, which shows the areas of compensation that comes along. Yes, but this was when you could see that the arch is fallen. But like you can see in this image here, when you can see how on supination, there is external rotation of the tibia. So at that point, you would see an overactive nature of the entire chain from here to there, which might present with the same issues that even the fallen arch also presented. Yes, there is a larger load on these tissues because they are completely doing the extension work in the running gait, and you would see that a lot of them resort to again handling doing some overload work on the glute medius. Yes, glute medius work is very important to kind of stabilize the hip, but if you go about doing the same rehab that we did for the fallen arch, you would see that many of your symptoms might get aggravated because, like you can see, there is a double loop that is created by this line. So it goes around the foot and again crosses over. So the pattern of pain might be represented, or the injuries that you might see with this is the same, because you're again looking at issues with gait, issues with extension as well. So when you're doing the rehabilitation work, what is important to understand is that you need to first do myofascial work, obviously through either foam rolling or targeted foam rolling or targeted soft tissue work or self soft tissue work that you can do. But at the same time, you need to understand that you need to overturn the compensatory pattern. So and I've seen a lot of them consistently look at an adductor involvement in being an issue in any of the hip patterns. Yes, we've seen that due to an over dominant adductor, you would see that the glutes not kicking in very well, or there is too much of force that the glute medius needs to handle. But what is important in a condition like this is where I kind of look at it differently. If you can see the image to your left here, so you would see the pattern of pain completely along the same line all the way there, because this is only the muscle that is working for extension, and that is not sufficient, because if this external rotation torque which is created here because of an overuse, we need to make sure that we get right alignments of the foot when we are doing corrective work as well. So that's where it's not yes, we need to look at glute medius function, but we need to look at glute medius function rather than strength. Yes, we need to kind of get activation of that area so we can kind of work better with the correctives. But if I go to the next slide, you could see I speak about orthotics in a bit, but since I'm in that, I try to try and see if I can get just the posterior chain working better with a foot raised or a toe up kind of a situation where I'm just getting pure posterior chain work happening, where I'm trying to balance out the forces of the lateral aspects that got tight due to the movement patterns that the athlete was using. So in an attempt to do that, we need to understand if there was no adductor muscles, if there was no adductor magnus, especially, which is a large thick muscle in the medial side of the femur. If this muscle is weak as well, all that's going to happen is the legs will just flare out. But the aim of any appropriate movement pattern is to get stability through the hip, which is created by equal forces on either side, which means the adductor magnus is as important as the glute medius and the piriformis and the glute max. It needs to be a counter force that is created, which keeps the femur nice and aligned and straight. So one of the aspects I see with people who are having over supination or supinated foot is that they externally rotate at the femur so much, and that's one of the reason why their gait patterns are dominated by landing on the outside of the foot. So like you can see here, I've kind of got important elements and isolated, like I spoke last time as well. I'm looking at local changes to happen, that is at the foot, at the core of the foot, at the hip, get them activated. Again, if you see, I'm actually looking at better hip flexion patterns here, where I'm trying to get the contralateral hip to stabilize, and because that's when you get complete length into the glute and the hamstring on the contralateral side. So if you don't have proper hip flexor activation, or which we now train for as hip flexor reflex, is when you plant the one leg and your knee is straight, like in this picture here, if it's straight, you would get great stability through your hip, in which there should be a reflexive hip flexor pattern on the contralateral side. This is really a key component to create stability at the hip. And a lot of the guys who are having high arches tend to flare their foot out and not have better hip flexor patterns as well, over dominant on the lateral side. So it's not sufficient to just consistently do myofascial work and rolling, because I see a lot of them doing a lot of myofascial work all the time. It's like, again, doing a lot of stretching, which I have consistently been speaking about in many forums about the dangers of overstretching, which is well documented, and there is enough research to be shown that it reduces power production by 18%, and that's a lot when you're looking at any function. So when you look at the correctives that you need to do, you need to make sure that the alignment of the foot is always forward and not externally rotated. And a lot of them who have this issue, I see them going and squatting with a flared out, with a externally rotated foot, which is slightly more than even 10 degrees. 10 degrees is manageable, but because of the restriction in the hip, they would do a lot more externally rotated squats. And what you're doing there, you're training the same old patterns where you're using only the external aspects of all the whole lateral line, for the squat movement, and you take those movement patterns into your running. So there is no corrective that has been done. So everybody would think that, oh yeah, I'm doing the right movement, but it's not really addressing the point. So that's why if you see the flow that I suggest generally is, apart from the activation work, which needs to be specific as well to address stability, mobility, and other aspects within, via assessments, we can kind of figure out what are the local issues that there are, local immobility issues or local stability issues that are contributing to the dysfunction, to the global dysfunction. So we can address it via activation. But when you integrate the whole chain, like I'm doing here, I'd rather prefer to do unilateral stuff, like the Bulgarian squat, so that we can actually get better hip position, and also to get better foot alignment, so that we can get the adductor magnus to work along with the glute max to give great stability at the hip joint for it to be stable through the whole extension chain. But again, if you see the next image that I have, I'm also trying to do a lot of hamstring related work where I'm getting the medial aspects of the hamstring integrated, because they are great, important aspects of hip extension, which can be done in a modified RDL or split stance RDL, that we can address these things. So you actually address the eccentric load that the hamstring actually undergoes during a running pattern. But at the same time, we could also address foot positioning and get the right musculature from the medial aspect of the leg to counter the force that has been created due to the gait patterns of the high arch. So getting this stability factor into the rehab is really a critical aspect to getting rehab right for high arch speed, because I see a lot of them going and doing again the same rehab, a lot of squatting, but they take in the same externally rotated femur positions in the bilateral work. So if that's happening, you're just going to keep going in loops. You might feel better, the glute feels better, I've not run for many days, you'll come back to the same thing. So you need to break that pattern, understand where the actual dysfunction is, and create balance between the muscles that handle the joint. To create stability basically means that there has to be equal forces acting on the opposite direction, and hence the joint remains stable. So that's what has to be the core of the rehab that we are looking at. Yes, one of the ways to handle, or which I have seen work best, yes, with the, like I spoke about last time as well, orthotics is a great way to start, especially for the high arch, because we need to change how the foot is distributing the load, and trying to center the foot's balance rather than take away. Generally, what would happen with the high arch is there'd be a lot of real foot varus and forefoot valgus happening. So to get this alignment right would mean that we get the right aspects in the calf and the post hip working better to create better control at the foot. So the orthotics is an important element, but as I've spoken before, I generally look at a 5 to 10 year period where we can do the corrective work, get off the insoles, and also start working with your foot and your running mechanics doing better. So you keep working at it. It takes a long period of time to kind of do that correction, because we've been utilizing this gait pattern for so long. Especially marathon runners have been doing this for so long, and there is so much continuous activity of the foot in a marathon. So to change these patterns, it takes a long time, and it's a more a neuromuscular thing than anything. So getting foot alignments, getting foot positioning, getting hip alignments to the foot, and how the core stacks up on it, and how the rib cage stacks up on it, and how the and that would be represented on how the neck position is when you're running. So it's just sometimes I just look at a running video and we could see the neck position and say what else, the rest of the chain going wrong. So like when I showed you here, this whole chain connects all the way there. You'll see a faulty neck posture, and we can kind of determine what is the pathway the compensations are. So um, so the corrective needs to be looked at a little differently than what normally everybody jumps to doing corrective work at the hip, trying to stabilize it by doing. That's okay for a start for activation, but the recruitment aspect of it, neuromuscular part of it, is better done when you are able to control your foot position, and you can take away a lot of the compensatory patterns while you can do a Bulgarian or an RDL like I've shown there. So it can kind of move on from that. So that's basically what is the concept behind how you can make a better corrective pattern for a high arch rehab. And then again, this is something I used on our last week's thing. It again, like you can see, it could present with the same issues as well. But I've also seen some runners with extremely high arches done large volumes in their high arches, a lot of anti-inflammatory work. And because of those high arches, they then started having laxity at the navicular, which then presents as a fallen arch because there was so much load going outside and they've not corrected the pattern. There is also when at foot plant, there is so much force outside, then they start slapping. We call it slapping of the foot. And they start slapping. And then the load on the navicular becomes so hard. Either they present with sesamoid bone fractures or even navicular fractures, or else the inevitable drop of foot. So you tend to see most of the common injuries here. But like I explained in the previous slide, the pathway to doing rehab has to be altered based on how specific your assessments can be. If you can get it right, you can understand the patterns right, and then you can do the myofascial work along with the corrective work, and that's when you have a really successful rehab. It's not all the time rolling. If someone's telling you to keep rolling all the time, there's something wrong in that, because if you're not progressing in the pain points, that if there is no changes in the areas where you feel pain when you're rolling, that means your rehab's not working. We need to do something about it. As the same thing goes to when stretching. If you consistently feel tightnesses in the same regions, that means by stretching it, you're just masking it. So you need to understand that your body has an innate ability to balance things and adapt to movement. But if there is a compensatory pattern and you haven't fixed it, you will again see tightness in the same region. So there's no point just stretching it. It's just a temporary fix. So you need to go to the core of the issue, balance the joint out, and then you'll see a change in these type areas as well. And coming to this side, like I said, these are the common injuries we've kind of looked at. You can go through the process of local to global movement correction, like I spoke about in the previous slide. But in general, this slide, I wanted to kind of pull out or give direction to how evidence-based practice can be implemented into this. We have a lot of, this is YLM sports science they have some wonderful infographics that they already use to show. And like you can see in the first one here, which is the most common thing, minimalist footwear to non-minimalist footwear. Again, I see a lot of these guys do this without giving enough adaptation time. It's a 50-50 chance that your body adapts to the changes that you put in. Either it adapts and you become a great barefoot runner, or else you just stop. So that's not really a good enough mod to kind of implement something. There's a way to go about it. Like you can see, even though from a metabolic advantage and a running efficiency standpoint, it actually has lesser gain by doing minimalistic running versus footwear, right? At the same time, I'm someone who loves minimalistic footwear, but that's because of a lot of barefoot running that I've done from the time I was a kid, and hence my neurological patterns prefer the proprioceptive feel of the ground to my feet. So that adaptation has happened from a young age. So you need to do the right kind of exercise rehab or conditioning to help your body get to a certain state to handle the loads that you're putting your body through. Without that, if you just have sporadic rehabilitation or sporadic running plan just to make up mileage, you just end up with compensatory patterns, or you just stop because you never found an answer, because the process of you went through for the rehab isn't coordinated or isn't structured. There is always a method of going through it. Like I said, I've taken a lot of guys, a lot of runners from being minimalist to wearing a little bit of a structured footwear. But I've also done the opposite as well. But it's based on how their body was reacting to the gait mechanics that we're trying to get them learn. So you can find a lot of these things. And I wanted to speak about. I put this second paper here because this is a new evidence that came about where we're using augmented reality, and I've utilized virtual reality and augmented reality, not necessarily augmented reality, but virtual reality for retraining a lot of neuromuscular patterns and during rehab, where we can actually use these new technologies to kind of create the environment in which you can train in, to give a closer visual and auditory input when you train, because it's an extremely important aspect that is not looked at in rehab. It needs to be integrated into rehab, into strength training, into conditioning work, and with the technology that we have now and easy access to it, it just makes everything much more easier. So I think that's what this slide was about. So I think we can kind of move on, and yes, like we did in the previous webinar, I think I'll open it out to both Bads and Sinan to speak about any cases that we've seen, case studies on that, any discussions, and also continue the Q&A.
Okay.
It's about 15% of the global runners around the world, I think, is only who have had high arc related injuries. That's how low the high arc rate is. But
yes,
I've also seen that, like the case I was talking to you about, where there has been people with a lot of high arc, where they've kind of where they, because of the high arch for such a long period of time, and also their fascia has been quite pliable, and the fascia is they generally have a very thin fascia. What they have a prevalence of having a lot of joint laxity, ligament laxity. So what tends to happen is that they start supinating so much that the foot begins to slap in, and because of the slap in, you will see that either they present with fractures at the sesamoid bone fractures, or the first MTP joint, or navicular fractures, or a drop in a navicular begins to happen. So if you're in a static position, you'll see that they might have an high arch, but in the dynamic phase, you'll consistently see this happening.
Collapse and all of that.
There's a lot of the time where this kind of so it's very important to understand. You addressed it last time in a previous webinar, where you were speaking about rigid foot to flexible foot. Flexible. They're really so flexible because the fascia is thin. And you see that because of that slapping, there would be not the force joint. The line of force is so targeted beyond the big toe towards the first MTP joint. So you'd see the helicis valgus happening and things like that beginning.
Okay.
Yeah.
Yep. Pradeep over here wants to know if will zero drop shoes help towards minimizing injuries?
Zero drop shoes. I don't really know what.
Even I wasn't sure. I thought you would know what zero drop shoes is. So I passed on the question.
Can elaborate on what this zero shoe is? Is it a new?
Can I unmute Pradeep for a second? Let me just unmute Pradeep so that he can describe it in first. Yeah, Pradeep. Yes.
So zero drop, most of the shoes, if you look at it, your heels will be a little bit higher than your forefoot. So as a result, like when you start running, like you'll be running more. So in zero drop, your heel and your forefoot will be at the same level. So the amount of cushioning, what you see, it's like almost better.
Got it. Okay. I'm not a very big fan, to be honest, of heel elevated shoes, but there have been times when I had to elevate the heel based on the foot assessment, looking at how the forefoot to rear foot alignments happen. But very rarely I've used more than a 1 mm or 2 mm increments. And that could be, and I've also utilized it sparingly to kind of counter limb length discrepancies, but I'm not. I've seen a lot of shoes because there were certain football shoes which came with a slightly elevated foot, which was very, very detrimental to my feet. I'm someone who's had a host of ankle injuries. I think I should get a degree on ankle injuries just for that.
Abhi's a resident expert on ankle injuries. Like, if any ankle injury that's there in the textbook, that's happened to me.
It
Like,
tends to happen, yeah. So, so I would consider my foot to be on the chronic end of the spectrum, where there has been so much of changes that have happened. I've got on insoles, I've gotten off them. Now, even Badri is kind of helping me kind of settle better ankle positions. He's been looking at different aspects that look at how my foot plant happens, and we've been working on certain aspects there. But if you see with my feet, the moment there was one of the shoes, so the shell of the shoes, that is the outer covering of the shoes, changes in different models in football shoes. And, and the reason I'm talking about football shoes because it needs a lot of lateral forces also that go into it. It's not just marathon running. We have one plane that we keep looking at. Yes, there is transverse plane, everything that we're doing. When I'm looking at the foot, I'm looking at just one plane. But at the same time, it's like a give and take between the lateral arch and the medial arch that happens during the whole gait cycle. And this give and take is important. So there is a lack of synchronization that can happen with an elevation of the heel at the same time. So I would suggest I've always looked at shoes which is having good alignment from forefoot to rear foot. It's always worked well. And I prefer structured footwear always. So that's where it is. That's my take on that, Pradeep. So on having an elevation or not is very, very, so the foot correctives is so specific to that person. It's better to look at doing a good evaluation, not just on the before you do it on getting a custom insole made or anything like that. We can actually do an end-to-end examination on a physiotherapist table. I can look at alignments. It's fairly simple, but you can get in-depth understanding of how the foot's in static position to dynamic gait. So then you make a decision on what needs to be supported and how. But it's just the supportive structure is not necessarily to manage dynamic load, but it's actually more to do with neuromuscular patterns that you can develop by having better foot mechanics, by assisted foot mechanics. So we can go from assisted to assisted, unassisted to just foot. That takes a little long time. So we kind of do that work. Then you'll see that the foot mechanics that you've learned neurologically remains.
The next question is from Saurabh again. He was talking about he was referring to the first session where he talked about the whole the shoe wearing out on the outside, even though over here. So he's like, even his shoes tend to wear out on that part, adjacent to the toes. So Saurabh, I'm just gonna like you to unmute yourself. We want to ask you a few follow-up questions. You have what type of foot you have, and all of that is relevant in such situations. I'll let you answer that. Is he here, Saurabh? Hello?
Yeah, hi Srinath.
Hi.
Can you hear me?
Yes, we can. So
so not very similar to what you had shown on your shoe. It was yours was towards the exterior part, right? It was on the, if I would call the right foot, it was towards the right hand side on your shoe.
Right.
Mine is towards the interior of the foot. So I would probably say, if you're getting my point, that is towards the interior part of my foot.
You have an arched foot, and even then the wear
and
and tear is on.
Yeah, it is prevalent only while I play, when most of the sports are taking place, the activities, only then it is there, and more predominantly on the left foot, not on the right foot.
Okay. What sport do you play?
Do you wear? Sorry.
No, good question.
Basically, I play badminton. That's the predominant sport that I play, badminton and squash. Okay. So yeah, I would use Yonex footwear, yes.
Okay, fine. How long have you been playing?
So it's been close to about 10 years or so. Yes, 10 years.
And you have consistently noticed that there is a wear and tear on the first metatarsal?
Each and every one shoe that I buy, it will probably last for about 3-4 months. And my mother generally has the same issue that on the left shoe, there is always a big hole there. And that's only there on the sides. And the sole of the foot and the shoe is perfectly all right. But just that the left shoe is damaged on the left side. Yeah, that's the concern.
Is the shoe size correct to your foot size?
Yes, I have. Over time, I have got to know what is the right size for my foot. So I have probably gotten that. There's no issue with the size as well.
Okay, and how long does it take before it starts to wear out?
I would say, Doctor, probably, I would say 30 days or 40 days, just about a month. Within a month, and probably, when I start to notice, when I start removing my shoes, non-marking shoes, I happen to notice that, there is a big hole.
Okay. And do you play doubles or singles?
Yeah, I'm predominantly a doubles player, but I occasionally also play singles.
So this is competitive badminton, yeah?
Yes.
Okay. Have you sprained your ankle?
No, I haven't. I've just had a slight niggle, but no serious injuries.
Okay. Is there any other issue up the joint, either in the ankle or in the knee?
I've had issues with the knee before. That is, I had fallen down once and I probably aggravated a knee. I had an aggravated knee injury, but nothing with the ankle so far. But major issues is with regard to the sole of the foot. Sometimes it tends to, I have a little bit of sores, probably dryness and those kind of issues, heel cracking and all that. So that is just occasional, but not regular. Yeah.
You're a right hand player,
Right hand player, yes, Doc.
but your shoe on the left is what gets
Yes. Correct.
It's interesting. Okay. Is there a tendency for you to drag your back foot in either of those games?
Yes, I have observed that. Yeah, especially the left foot. I think that's what a lot of people have also told me, that you tend to drag your left foot sometimes when you try to reach for probably drop shots, or when you try to stretch yourself. The left foot, I tend to drag that.
Yeah. Okay. Is that wear and tear primarily because of the drag?
I would say so, because I do not tend to generally observe how I play. I have not seen my own videos and as such. But from what what feedback I've been given, I think I have noticed that dragging is there. Sometimes also the skin on top of the left toe also tends to wear off.
How old are you?
So now I'm 23, Doctor.
Okay. And how long have you been playing?
As I mentioned, I think around 10 years. So
10 years. Okay. Do you find backhand easier to forehand or vice versa?
No, I'm a forehand player. Yeah, backhand is slightly difficult.
Difficult. Okay.
Yes.
Is your leg length versus torso length? Is there an issue there? You have long legs?
No, not that disproportionate, Doctor. No, not that disproportionate. But I would say both of them are probably towards the same ratio. But slightly more on the leg is slightly more longer than the torso. Yes.
Okay, and you find it difficult to pick up drop shots?
Yes, I generally what I've noticed is my game is quite kind of attacking. So drop shots are not my go-to shots.
Okay, fine. So okay, there are a couple of things here that I can kind of put together, but this is by no means inclusive.
Yes.
One of the things that comes to my mind is that if you struggle to pick up a drop shot, either in squash or in badminton, then your tendency to get to the drop shot is from a heel dominant position,
Right.
or a foot dominant position rather than a forefoot dominant position.
Right.
So that means we need to consider looking at what is your position on the court on your 2 feet. Are you on your forefoot or are you on your midfoot?
Let's say most of the time it's on the forefoot, Doctor.
Okay, Suruba, I want you to write down these questions for you to think about.
Right.
Okay, because you don't have a video, I'd like you to think about it in your head, so to speak. One is to figure out where your position is on the court. Are you standing on forefoot or midfoot? Two is look at your strategy of shot. If you're gonna hit long shot, are you still waiting on your forefoot, or midfoot, or are you positioned more on your forefoot? Three is see if you can get a video of somebody who has videotaped you on a game, and then ask them to send it to you, and you can share it with us. I would also go ahead and say 4 is look at your own sense of center of gravity on the foot. Sometimes articulating that center of gravity over the foot becomes the key element in moving forward.
Right.
Those would be the 4 top things I would say, and then we can figure out more information from that.